All right, everybody. I'm Dr. Ben England. I'm the CEO of Torrentia Medical Education. I'm joined here with Townsend, the CEO of NuvoCell Biologics, along with Dr. Raymond Butts, who's the Chief Research Officer for Torrentia Medical Education. We're really excited for another live webinar Wednesday. Today, we're really going to be diving a little bit more into exosomes and kind of understanding the science behind the exosome biologics and really how exosomes differ from other biologics such as PRP injections, BMAC injections, adipose-derived stem cell injections, etc., and really break down how they're similar and how they're different. So thanks, Grant, and thanks, Ray, for joining me.
Of course. Happy to be here, as always.
Awesome. So I'll pick on Grant first. Grant, can you just give everybody a 10,000 foot view really quick of what NuvoCell Biologics is, and then maybe tell me a little bit about what are exosomes and why they matter?
So, NuvoCell is a topical transdermal exosome-based product. So, what we have done is taken the exosomes from mesenchymal stem cells derived from the Wharton's of donated umbilical cord tissue, all sourced within the United States. We've encapsulated that in a lipid nanoparticle, formulated it into a topical cream, and then combined it with some transdermal agents so that you can get a shelf-stable or refrigerated-stable topical product that will drive those exosomes into musculoskeletal structures. So, really the main method of our product are the exosomes, and obviously, some of the IP we have is our lipid nanoparticle encasement, which is used as a stabilizer and delivery method. But when you really start to lock into what exosomes are and why exosomes are important, is it comes down to cell differentiation versus cell to cell communication, or the paracrine effect, right? So as we know, when stem cells are in an area and they're doing their regenerative work, a lot of that work is through what we call the paracrine effect, which is delivering of these different biomolecules. So that's essentially what exosome is it's a specialized delivery chuck, right? So these exosomes are secreted from the stem cells, and they're carrying hundreds of different types of growth factors and cytokines and microRNA and proteins that influence these different repair pathways that can revive cells, influence cells into influencing repair and the regenerative state in the joint or whatever you're working with. So, if you really think about exosomes at the end of the day, it's a delivery vehicle, and the reason they're so unique and why they become so popular is because one of their nanovesicle size, typically between 30 and 150 nanometers. So what that allows them to do is, cross different barriers within the body, migrate within the body, and then also the fact that they have, natural homing tendencies through using chemokine chemical trails by their CHX receptors, and Ray, we've talked about PAMPs and DAMPs before, to be able to home in to damage tissue sites. And then really what's important is, I think it's interesting to me, we get so excited about exosomes, but what really matters is the proteins, right? The exosomes are just a way to deliver the proteins, but at the end of the day, if you don't have the exosomes, you can't deliver the proteins. So that's what it is.
All right. Awesome, Grant. Thank you so much. Ray, I'm going to pick on you a little bit now. Can you maybe give everybody a 10,000 foot view of maybe some of the differences between PRP, BMAC, adipose derived mesenchymal stem cells, and exosomes?
Well, that's a loaded question, but I think the big difference is that everything that you just listed there is all cells, and exosomes are not cells. They're the vesicles that are released by stem cells that have a lot of the growth factors and cytokines and things that are inside, right? But that's what makes this such a special thing for rehab professionals, especially since most of our scope of practices say, number one, we are not allowed to inject anything, and number two, we're not really allowed to administer actual cells. But when it comes to vesicles of cells, then that becomes a different story, right? So, in that case, then we're really looking at much more of a very special topical agent, in which case we can definitely play in that world. Another way to think about it is, of the different things that you mentioned there, platelets, white blood cells. We know that PRP is normally leukocyte rich, and if you think about why we're doing that in the first place, it's because inside platelets are like a smorgasbord of all these amazing growth factors, right? And if you think about white blood cells are releasing cytokines and interleukin factors. Well, it turns out that all of those growth factors and all of those cytokines and interleukin factors, if collectively, they're all really paracrine factors. They're extrinsic signals that provide instructions for the cells in the tissue and even stem cells to tell them what to do. And by tell them what to do, another way of saying that is it really it kickstarts all the different cascades which are inside cells, which tell them which parts of the DNA that need to be transcribed and which proteins need to be produced. Because, as Grant said, at the end of the day, the most important thing when it comes to cells are what proteins they create. Because, as I say in class a lot, much like the tail wags the dog, the proteins that cells make are really responsible for what those cells are going to do, what they're going to differentiate into, what their job is going to become, et cetera, et cetera. So if you think about it, I mean, these vesicles that we're talking about, that comes from the Wharton jelly of umbilical stem cells, which is a really cool thing right there. I mean, it's really a compilation of the most amazing things that you would find in a lot of the biologics that we're really trying to use as injections right now. So if you take all of the different signals that come from PRP injections and all of this sort of stuff, and you kind of take the greatest hits and put them all together, I mean, that's really what you find packaged together in all of these vesicles, which ideally we're trying to apply topically in order to bring them where they matter in a concentrated form.
No, that's great. And one of the barriers that we talk about, Ray, and I know Grant, we've talked about this too, when it comes to some of these injections like PRP and PRP lysate and, doing these BMAC procedures and adipose-derived stem cell procedures is one, often the procedure, there generally could be some downtime associated with that. And generally speaking, what you do from a rehab perspective is critical, before and after really an individual who has received a biologic, injection. But the cool thing about, exosomes, specifically NuvoCell, Grant, that you guys have is, from a rehab perspective, it really gives providers something that they're able to do kind of in the in-between gaps, meaning between visits, they're able to do it, more of as an additive effect to everything else that we're doing, because many of the advanced technologies such as Shockwave, Class 4 laser, electric dry needling, electroacupuncture, etc. What we're doing also signals to the body to stimulate or promote or provide a reparative effect in conjunction with NuvoCell. Ray, what are some of the conditions that you find that biologics in general, specifically exosomes, like where is the rehab research really concentrating in terms of conditions? Like what are some of those conditions that providers might really consider, or patient types, I would say, when looking at a biologic procedure or exosome procedure, who is appropriate, who's not appropriate? Really just talk to me briefly about that.
So another loaded question, but yeah, I mean, look, I think you see most of the research in any sort of degenerative pain-related conditions, the stuff that we would treat most often in the clinic. But I think the big thing is the literature that you're seeing on exosomes is exactly the same as what you're seeing when it comes to injected biologics, right? So really across the board. And as you said, I mean, it's one thing to be able to administer one time and be able to drive a reparative response. It's something else if you can receive a biologic and then do all of the things that we do in the clinic with all these different technologies that we talk about in class, whether it's laser or shockwave or multi-waveform technology and all of that. But it's really something else if we're able to use these exosomes as part of our clinical treatment, but then also be able to get patients to continue to do it, even on the days where they don't have rehab or they're not going to be coming into the clinic, so that they can continue to provide the right instructions to the right cells continuously over the course of that rehab.
Yeah, I would say too, one of the things, that I also will discuss in terms of differences is cost. In Fort Wayne, Indiana, typical PRP injection is anywhere between $1,200 to $1,500 for a PRP injection, maybe a couple $100 more for a PRP lysate. Many of the adipose-derived stem cell procedures and BMAC procedures range anywhere from $2,500 to $5,500, depending on the procedure. And many of my patients, in Fort Wayne, mostly blue collar town, 250,000 people, the price point, from NuvoCell, in using these exosomes, with patients, the price point is much more approachable, and patients have more chances with these signaling pathways, kind of the in between rehab visits and on a daily basis, really to influence repair. I see that some of the research, Ray and Grant, you'd probably agree. I mean, much of this is surrounding, as Ray stated, degenerative conditions, osteoarthritis, as well as tendon injuries. We're starting to see more and more on biologics and nerve, related injuries and others. But it is really kind of an exciting time to see where the literature is going. Grant, back to you. When it comes to exosomes, talk to me a little bit about we'll just call them scientific mechanisms, and what is scientific when it comes to these biologics versus how can providers best equip themselves to sift through the marketing crap and the marketing hype, because there are a lot of companies that claim that they're providing or promoting, here's exosomes or here's stem cells or here's this, but how are patients and providers able to sift through that in today's society, especially with social media and Instagram and artificial intelligence and you name it? It seems like everywhere I look, I'm getting bombarded with another ad for yet another regenerative type, supplement or exosome. How can providers really be equipped?
Yeah, I think the big thing there that's blaring is everyone talks about exosome counts. Do you have 50 billion, 100 billion, a trillion exosome counts? And to be honest, a lot of that is marketing play. When you look at how the major manufacturers are measuring exosome count, they're using DLS nanoparticle count, which if you research it, you'll find DLS basically measures all the nanovesicles in the formula. But there's no way to validate what's an exosome and what is not an exosome. So really, it's an estimate of how many nanovesicles you have in your formula. What you really need to look at when you're just talking about pure potency of what you're evaluating is protein concentration. So one, knowing what proteins are measured in the product, and then two, what the concentrations of those are. For example, if you were to compare like one of our 30-day kits to an injectable, right? We advertise 1.8 billion exosomes, but we also have 200,000 picograms of alpha-2 macroglobin A2M. Right? If you compare that to some of the injectables that claim 50, 100 billion exosomes, their A2M measurements aren't even close. So that's I think that's really the big glaring thing. The other things you got to look out for too are obviously source. Right? There's different sources versus cord blood, Wharton's jelly, placental tissue, and there's different protein concentrations for each. Right? The Wharton's jelly is known for being one of the most potent in terms of number of mesenchymal stem cells, and then also being immunoprivileged, which means that there's less chance of immune rejection in the body. And then the other, obviously, I think the other clear things are, one, is it a FDA registered lab? Are they within the U.S.? Do they have their registrations? You can actually go and look that up on the FDA registry website. And then, are they doing proper storage? Is it for an injectable, either needs to be lyophilized, which is basically a freeze drying, or a cryo frozen. either shipped to you in dry ice or stored on liquid nitrogen. So yeah, I would say those would be the big ones.
Okay. Yeah.
I mean, just as a comparison, I think it's interesting to point out. Like, I mean, I have a patient right now in Miami who just spent close to $30,000 going to South America to get Wharton's jelly in both the knees and her shoulder. So, you really are having people that are flying all kinds of crazy paces. They're paying like a ton of money. And I mean, essentially, the exciting part about what we're talking about here is these are all of the instructions that are coming from all of those cells that people are paying all this money for, that we're really putting together in much higher quantities, within the context of a cream, and then empowering patients to do it in the United States, which I mean, I don't know. I mean, we spent a lot of time like looking at the research and talking about regenerative medicine, but like just that concept is mind blowing, right?
Yeah, and I think I always try to be level-headed in this, right? And I think, the one valuable or viable counter argument for doing the full cells, in my opinion, is once the cells are injected, right, they're starting to deliver their signals, they're going to give a custom concoction of those signals depending on what type of area, what injury they're dealing with, right? But also, the flip side of that is how long are these stem cells staying viable once you inject them, right? And I know we've talked about that before as well. So there's always kind of a flip side to it as well.
Yeah, because really what we're looking at overall here is non-surgical, we'll call it really non-invasive, intervention with patients. And I mean, really that's sort of the crux of rehab as a whole. I mean, regardless of your professional, I mean, I hope that the goal is to avoid surgery as much as possible. And I mean, we know that, as we've discussed, exosomes, they influence tissue regeneration, tissue repair, they assist in immune modulation. We see the growth factors, as Ray mentioned, with angiogenesis and cellular communication. Ray, what are some things that you think providers should be aware of when it comes to using these exosomes and technology? I mean, are there things that people should do or not do, they should avoid, not avoid? I mean, really, what do you see as something that they should be aware of when it comes to using advanced technology and exosomes?
Yeah, I mean, if you think about all the different technologies that we talk about, in class, I mean, the purpose of all those technologies are really to be able to exaggerate, manipulate, or to control a lot of these intrinsic and extrinsic signals, right? And so we're really just trying to do it so that all of that happens in vivo in the body through the course of treatment, so that we really keep the stem cells on track doing what they're supposed to do so that we can optimize repair. And if you really think about it, it's the same concept that we're talking about with these exosomes, right? It's just, can we continue to provide the instructions and all the factors that we're talking about, even when the patient's not in the clinic. But to your question, there are definitely a lot of considerations as to doing it within the context of physical therapy, like how best to do that. And when it comes to that, it really depends on what we're talking about, right? So the story changes a little bit based on the physiologic mechanism of the technology that we're talking about or the technique that we're talking about. For example, when it comes to using electric or to using maybe focused shockwave, that might be a really nice thing to consider after applying exosome cream, because in doing so, we could really use it in order to push these exosomes with all of their instructions and signals deeper into the tissue where it matters. On the other hand, if we're talking about something like photobiomodulation and using light or laser, well, in that case, I'm not saying the two don't couple, but to do the cream first doesn't really make sense, because there's a lot of lipid aspects to that cream, which in turn is going to absorb or refract the light that we're trying to get down to the tissue. So in that case, it would more interfere. So the point being, in that case, you would want to do the laser first and then do the cream afterwards as a way to reinforce what you just tried to do with the laser. So we're really working all together, with NuvoCell, and that's kind of our job, is to incorporate this, this exosome cream into, our iris method and all the different things that we suggest according to tissue type and stage of healing and all of that. But honestly, it's to figure out how best to provide exosomes in a way that physiologically makes sense so that patients ultimately get the most out of it.
Yeah, oops, sorry. Go ahead.
Oh no, I was going to ask Grant, which since we're getting into the more of the science, I know that one of the big things that physicians often ask, and that becomes a little bit confounding, is this business of DMSO. And I was on some meetings this week with Grant, and I thought his answers were really great when it came to all of that. But I think it might really benefit the the people on this webinar just to kind of hear, like, so that they're prepared when they're challenged with exosome cream and DMSO, and why that can be a little bit of a sticking point, given its history to also treat inflammation. Grant, would
Yep.
you mind just running through what the controversy is there, and why the very small amount, that is in this exosome cream has it's more of an advantage, and why it's advantageous, and why it's really not confounding based on the quantity?
Yeah, so it's a good question, right? And basically the question being that obviously we use DMSO in our product, and DMSO being a delivery vehicle, but DMSO has also been used as a powerful anti-inflammatory as well. So, the question being, how do we know if it's DMSO doing the work or the exosomes doing the work, or what, right? And the answer to that is one, we use a very low percentage of DMSO in our product, less than 5%. And we're just trying to use that small percent to disrupt that lipid bilayer to get those lipid nanoparticle encased exosomes through the dermis. And then two, when you go and look at the literature on all the studies done with DMSO, everything I've seen that I've read is all concentrations showing actual inflammation benefit or pain reduction, or all concentrations of 50% or higher in terms of DMSO concentration in a topical. So, and anything less than that, they basically say outcomes are not measurable. So that's pretty much what we stand on when we get asked that question, which I think it's well versed in the literature. And there's also the flip side to that too, because the literature will also say that for DMSO to be effective as a penetrator, it needs to be at a higher percentage as well. And the reason that we keep it in a low percentage is that DMSO, because it is a powerful solvent, can actually denature exosomes as well. So there's some unique proprietary technology and processing methods we use to be able to combine them together into a cream to not denature the lipids and the exosomes and keep them stable.
No, that's great. Grant, can you also talk a little bit about just kind of circling back to this a little bit in terms of kind of marketing differences? I see quite a bit in terms of exosomes aesthetically versus exosomes for clinical use. Could you maybe talk a little bit about the differences between both, and maybe just a brief overview of the regulation surrounding both of those?
Yeah, so really the regulation comes down to minimal manipulation. So you'll see the regulatory phrases on some of the labs that say we follow minimally manipulated protocols. So what that means is for cosmetics, obviously you don't have to follow that. For anything therapeutic related, you do need to follow that. And what that's stating is that you are not expanding or expressing the stem cells to release excess exosomes, right? So whether you're putting stress on the stem cell, you're putting excess oxygen in, or whatever you do to get the stem cell to express more exosomes so you can get a higher exosome count is typically what they do in the cosmetics, right? And that's why you'll see some, very high acclaimed exosome counts, which we already talked about. That doesn't really mean much. It's all about the proteins, anyway, when you go into therapeutic and like what we use for our product, it's there's no expression or manipulation or anything in there. But I do believe that's going to be something interesting to explore in the future because I know we've talked about this on here as well, right? The way a stem cell works when it's in a certain environment, it's going to release a certain type of exosome with a certain type of payload. Or I shouldn't say a certain type of exosome with a certain type of payload, right? Because exosomes can carry multiple different types of payloads. So I think one of the interesting things that's going to be to explore, going forward in the future, and hopefully as regulation continues to change, is how can we, are there going to be exosomes for osteoarthritis and exosomes for tendon issues, exosomes for neuropathy. I think there'll be a lot of cool things to explore there.
One of my favorite things that you always talk about is the amount of A2M which is in the vesicles of the exosome cream, and obviously that's a really big deal because we know that the latest PRP injections that really include A2M are really showing great results when it comes to osteoarthritic joints. So I don't know if you're maybe that's all there is to say about it, but just the fact that A2M is really there, in higher concentrations, in each of the individual vesicles in the cream, and that, we could really apply it over top of osteoarthritic joints and do it consistently, the potential there is very cool.
Yeah, definitely. And when you look at our protein composition, A2M is actually the most potent protein in our mix by 2x, right? So it's the next highest concentrated protein is 100,000 picograms that we test for. And for those of you who don't know A2M, it's a broad phase protease inhibitor, right? So basically, it neutralizes the enzymes that cause degradation, that cause osteoarthritis, which is, I think why it's becoming so popular and driving such great benefits.
Yeah, we're seeing many physicians, Ray, I know you are too, actually doing A2M injections in combination with injectable biologics. So the precedent has been set. The precedent is there. I mean, it's just we're waiting now on, how much does it, generate long-term outcomes. Ray, you talk quite a bit about outcomes, and we talk about how as much as we love, biologics, there are definitely some shortfalls to those. Meaning, if you look at the data and the research specifically with BMAC procedures, is they do work. They just work over a very long period of time. I mean, the most recent review in 2024, we saw that it was 4 years after that we actually saw the greatest benefit for patients following BMAC procedures. And I would say that many of our patients, Ray, you talk about this quite a bit, they don't have time to wait 4 years for something to work. But those same signals that are being provided by the BMAC injection are also being provided by the exosomes.
Yeah, I mean, just like we talk about in class when we talk about even dry needling, right? Like, it's one thing to tell the cells one time what needs to be done, right? Or to even tell them, 50 times over the course of a treatment what needs to be done, right? But the power of continuing to remind cells every single day what needs to be done in order to be able to fix that tissue, right? That's where the true potential lies in being able to shorten the timeline that you're describing when it comes to regenerative medicine, because you're right. Like, the latest studies are really showing that it's not that regenerative medicine isn't useful and it doesn't work. It really seems that it just takes more time than even what we thought, right? And then the question there becomes, well, are patients really willing to invest in those orthobiologics given that it takes more time, or are they going to go a different route just because it's quicker, right? And so, I mean, that's then our job, right? Is to figure out like all the amazing things that we do to include exosomes. How much can we actually shorten that timeline, right? So that we can really increase the efficiency in which these stem cells act, so that we can ultimately, make what we're trying to achieve, and when it comes to all these orthobiologics, much more timely, in a way where it really fits with patient lives and return to function and all of that.
Yeah, real quick before we get to our question from Light MD, Ray, can you quickly just mention? You mentioned it on the course, this past weekend when it came to, I believe it was the X, or I'm sorry, the PRP counts. Can you maybe talk through the differences of maybe why patients are getting multiple PRP injections? Because really, it fits the context of this, right? Like in terms of the exosomes, but could you just talk a little bit about maybe why a patient would consider getting multiple biologic injections like PRP or stem cells?
Yeah, so what we're finding is that not all PRP is created equal, right? So, you know, if you look at the different variables that make some PRP more successful than others, we know that one of the primary variables is the number of platelets that are in the actual injection, right? And so what we know is that when it comes to tendinopathy, that the threshold of the number of platelets that are required for a successful outcome are between 5 and 10 billion. Right? When it comes to an osteoarthritic joint, depending on the size of the joint, we know that the threshold is 10 billion platelets, right? Now, there have been two major studies that have really shown that these thresholds are important. One actually would suggest that the PRP injection that's being provided needs to exceed those thresholds within a single injection or treatment with orthobiologics. The other actually shows that as long as you're providing multiple injections that add up to those thresholds, that that also is okay, but that argues heavily for the need for boosters, right? And more than likely a single PRP may not be good enough depending on what you're getting, right? That you really may need to have a series, right, which actually gets to those thresholds. um, so there again, you know the point is what is it that we can do, in between time, in order to kind of be able to plus up what all those platelets are really providing. So the more of them that we can keep healthy, the more of them that we can keep in the tissue where it's needed, and the more of them that we can keep working, can we begin to drive down that threshold so that maybe less platelets are required to get the overall effect, simply because we're filling in the spaces in between with all the amazing technology that we have, and by starting to use these exosomes, which really means that rehab needs to be part of the process.
No, that's great, Ray. Question came through about what about patients with post-op recovery, meaning using exosomes with for post-op recovery and scar tissue?
Yeah, the answer for both of those is one, post-op I think is a great application. Even pre-op too. We recommend that in some of our protocols if you have a patient going in for a knee or shoulder or joint replacement, doing some preemptive NuvoCell to get the environment, get the joint primed, and starting geared towards a regenerative environment. And then after as well on many different levels, right? I mean, depending on what type of surgery you're using, there's going to need to be some type of reconnection or growth or healing. Obviously, there's going to be all the incision marks, the cuts into the muscular, the into the different tissues that needs to heal. And then specifically on the scar tissue, so exosomes naturally have very good anti-fibrotic capability. So decorin specifically, which is a protein we test for, is a pretty potent anti-fibrotic protein that kind of works hand in hand with transforming growth factor beta to moderate its extracellular matrix remodeling. So yeah, long answer to that, but definitely good candidates.
I mean, remember, transforming growth factor beta is arguably, one of the number one things that is transcribed by the transcription factors AP1 and NFK beta, right? So transforming growth factor beta plays a bunch of different roles when it comes to regenerative medicine. Not only does it provide a positive feedback cycle, it's also involved in angiogenesis, right? And when it comes to scar tissue, remember, transforming growth factor beta is responsible for calling the cells, the tenocytes, the fibroblasts to the area, and then pushing those cells in order to make the collagen fibers that are necessary for repair. That said, it also monitors exactly how much collagen fibers are being produced and released, to the point where if it starts to become excessive, transforming growth factor beta actually shuts it down to ensure that the body doesn't start to produce fibrosis and scar tissue, right? So very, very cool thing. And if you think about it, transforming growth factor beta is one of the key elements that you find in exosomes, and it's also one of the key elements that you find in PRP lysate. Right. So one of the big advantages of PRP lysate is you take all the platelets, you lyse the actual platelets away so that you concentrate only the stuff that you find inside platelets. Right. And in doing so, one of the big advantages then is that you can actually inject a more concentrated form of transforming growth factor beta. And that turns out to be one of the primary reasons why PRP lysate is so advantageous, especially when it's used with nerves, right? Because injecting into the perineural tissue in and around nerves, the last thing that you want to do is form excessive fibrosis and scar tissue that could adhere to the nerve, and then obviously that's going to create more of a problem. So the point there is that transforming growth factor beta is one of the special qualities that makes PRP lysate such a big deal. And it turns out that it's one of the primary factors in exosomes. And so the advantage there is really the same.
No, that's great. Ray, what are some of the technologies, if you want to remind everybody, if you want to catch our past webinars, we've talked extensively about the technologies involved, and how we can implement those with exosomes. But you want to briefly just mention some of the technologies that increase, the activity of transforming growth factor beta and some of the other very same growth factors that are present in PRP as well as in exosomes.
Yeah, I mean like I always say, like I think that the top four technologies of the future are really photobiomodulation or laser, right? Class 3, class 4 laser. I would even say radio focused shockwave, multi-waveform technology like ARPWave is a great example of that. And then I would also include hyperbaric oxygen. And then if you want to do that locally, you see a lot of physicians starting to talk about ozone therapy, which is more just like a concentrated version of what hyperbaric oxygen is doing in the tissue where it matters. And then I would really, based on the literature, I would give an honorable mention to EMTT. EMTT is really just a concentrated version of PEMF, right? So you really could say it's like 100 times the normal power of PEMF. Obviously, that's more of a magnetic technology. But if you really think about it, the purpose of every single one of those technologies is to increase the intrinsic and the extrinsic signals that you would find in the extracellular space in and around cells, which ultimately is able to activate a lot of the cascades that we would associate with regenerative medicine, like the ERK pathway or the AKT pathway, just two examples. Because at the end of the day, these pathways give us the really important transcription factors, AP1, NFK beta, which are able to transcribe the parts of the genes that are responsible for making the proteins, which is the most important thing. And these proteins then dictate cell proliferation, so cells making more cells, the longevity of those cells, meaning how long those cells are able to exist and do their job, the differentiation of those cells, meaning cells turning into cells that are necessary to repair the tissue, and then the migration of cells, the right cells, to the tissue, which also assists in that repair. I mean, if you really think about it, those are really all of the major things that need to occur when it comes to regenerative medicine. Exosomes is really just another great way of getting there because, as we've been talking about, I mean, they're really just vesicles that are filled with the very same extrinsic or paracrine factors that are essentially able to do the same thing. And as we've said over and over again, what makes them really so special is not only can we use it to exaggerate what we're trying to achieve with all these technologies in an additive way during treatment, we can also continue to get patients to use the exosome cream in between treatments to continue to communicate to these cells in the right way so that we can maintain the reparative response that's happening to ultimately make that repair as efficient as possible.
Oh, I love that. That's really good, Ray. Grant, what are some of the challenges that you're seeing some of your private practice owners face? I know there's quite a bit of new legislative changes, such as in Florida, and there's some new things going on in Tennessee. Do you want to just briefly touch on that? I know I didn't really prepare you for that part of it, but I just know that the State of the Union is important. We've been doing kind of a peptide series as well this month. And in the peptide series, obviously with everything going on in the news with peptides, some being removed from category 2 and maybe being put on category 1, and there's just a lot of legislation. Like there's a lot of hoops to jump through. So I'll maybe give you an opportunity to talk about some of those barriers and maybe kind of what's going on when it comes to regulation. And I'll just let you speak freely on that.
Yeah. I think the regulatory environment of biologics right now is evolving extremely fast. So, I think it started with Florida and Utah. So Florida passed the bill last year. Utah, I think, was around the same thing. And then recently, as of April 30th, Tennessee just passed a similar bill. What all these bills are putting into place is directly allowing physicians within the state to perform stem cell injections. There's certain guidelines around them. I know, I just read Tennessee's legislation yesterday, and they have to go get a certain accreditation from one of the anti-aging accreditations or biologics accreditations. But a couple interesting things about that is, one, those legislations completely contradict what the FDA says. So it's like one of these it's like one of these things. It's like it's wild west in terms of legislation right now. But I think from what we're hearing in terms of the FDA is that's rapidly changing too. I've heard a lot of whispers and rumors on RFK wanting to push forward with that. I know he's obviously pushed forward with the peptides, right? So with that, I think it's really exciting that these states are starting to put forward these legislations because they're basically saying, hey, we're not going to keep waiting on the FDA. We know, providers are doing this anyway. We need to put legislation in place and make sure they do it the right way, make sure they do it safely and ethically. And then the unique thing about that and where we fit in is obviously it's creating a lot of excitement, right? Everyone's talking about it. I was telling you before we got on, I've had 3 meetings with people from Tennessee this week, just about excitement around that bill. And each of those bills that I've read there, so they actually exclude cell factors or cell-free products like ours, which is a good thing, right? Because those legislations that are getting passed right now do, I know Florida specifically restricts injectables to DOs and MDs. So obviously physical therapists can't do it, chiropractors can't do it, acupuncturists can't do it. But the fact that these bills are getting passed, but they're saying that cell-free or exosome products are excluded for that is I think is good that the legislation's moving in the right way. And then, I'm sure in the near future, we're going to see some legislation start to move around exosomes or cell-free products as well. But, at the end of the day, that's one of the great positionings of NuvoCell is, one, that it's cell-free, but two, that it's topical. It's very risk adverse, right? So, it's not that there's no risk, but, the risk is very minimal, right? When you look at scope of practice, pretty much everyone can use topicals in their practice within their scope of practice. So, it's a unique environment right now. It's changing very fast. We're actually bringing on a compliance officer right now to help us keep up with all of it, because it is changing so much. But it's exciting times.
Yeah, we
The other
also
thing
go ahead, Ray.
I was just going to say the other thing that I think is important to say is we talk about using exosomes as a way to supplement orthobiologic procedures or other regenerative medicine. But I think it's important to say that a lot of people can't afford orthobiologics. Like PRP, certainly stem cell injections, it's really, really expensive. And so, one thing that I think is interesting about this exosome cream is it really facilitates bringing regenerative medicine to a population of patients where regenerative medicine was formerly out of reach, right? Because it really is something where patients are able to do it on their own, right? So it empowers them, but it doesn't require a physician. And it's, in most places, the vast majority of places, it is considerably cheaper than what it would be, to do a PRP or a PRP lysate or really anything else. So you think fancy exosome cream, this is only going to be for rich people, probably raise killing it down in Miami, but I'll tell you, it's not really a Miami sort of a thing because that's where most people can afford the expensive stuff. Where I think exosome cream is so special is really the place where no one else can afford anything else, right? So yeah, I mean, just to be able to have a tool to be able to provide everyone and make it attainable by everyone, I think is worth pointing out.
Yeah,
Yeah,
no,
and that's sorry to cut you off there, Ben, but I mean that's our mission statement, right? I mean, the reason I got involved in this space was using earlier editions of our product to recover from a failed back surgery, and really just becoming obsessed with the space and realizing that one, it's out of reach for many people from a cost perspective, and we need to figure out a way to make it more accessible. And then two, it's the education piece of that. And so many people just don't know what regenerative medicine is, or just think stem cells come from aborted babies, and don't really know all these different avenues you can take to find very powerful rehab modalities.
yeah, I was Ray and I were actually teaching in Bristol, Tennessee area this weekend with a group of providers, and I one of the providers, just on kind of a lunch session, was like, hey, like, is this thing like, I mean, should we really be, kind of dabbling in the cream stuff, and should we do that? And I literally walked over to the front desk of the office and held up a bottle of Deep Blue, that patients can buy, and Voltaren gel and DMS, and it's like, well, if patients are able to walk in and purchase this, from your clinic off the shelf, then what's, okay, one's refrigerated, one's not. It's still a topical cream, So obviously, always check your state scope of practice. We're not telling you that everybody is completely able to do that. I mean, Torrentia, much like you, Grant, we partnered with a compliance company at the end of last year, and this year, we are in an ever-changing landscape when it comes to this regenerative space. I mean, Ray and I have been talking about this, for multiple years now of, hey, we've got to just be the first to create the first rehab certification, for regenerative medicine. Like we got to get this done. And then fast forward 3 years and here we are. And it's just, oh, and now everybody's interested in peptides. Everybody's interested in exosomes. We kind of felt like we were on an island when we started. So we were really happy to get to meet you, Grant, and really kind of solidify our partnership together, helping providers quickly get some of these things to their patients, and we really are excited about kind of the future of regenerative rehab and regenerative medicine as a whole.
Yeah, agreed. And I think the OBH approach is, in my opinion, the right way to do it. And that's what I did with my experience, right? Is I took kind of my own version of an OBH approach to help take me that extra mile past my back surgery recovery. So at the end of the day, what matters is patient outcomes, right? That's why we're all here. Is we want to we want to get the most optimal patient outcomes that we can, and by one, understanding everything that Ray teaches on the cellular level and how this all works together, and then two, how to pair the right rehab modalities with it. I know from my experience it works. I know so many people who've used it that approach works, and I think that's where this industry is going. So it's exciting to be at the forefront of it.
Does anybody in this call or in the Torrentia tribe have anything that they have questions on that they want to throw up in the chat before we close? We very much are excited about where things are headed. I mean, there's lots of legislation that's coming, and up and coming. So one of the cool things that we're getting to do with Grant is, we're getting to ready to launch one of our courses as part of our functional medicine and rehabilitation diploma is actually a specific course just on individuals who are interested in using exosomes in the context of advanced technologies and regenerative medicine and all of that. So we are excited to be partnering with NuvoCell on that. And so that'll be coming this summer, and we're really happy to do that. Okay, question is California Acupuncture Board. Let's see here. Let's see, approved CEU provider for California Acupuncture Board. We try and strive to accommodate all providers as much as we can, whether it's MDs, physical therapists, chiropractors, occupational therapists, etc. I'd be happy to chat with you. Michelle, you're able to email me, ben@torrentia.com. If you have a great strategy in terms of getting things, we'll call it approved in terms of the state of California for the acupuncture board. Ray and I tend to cross party lines very easily. There are certain states that have had many, we'll just call them court cases or Supreme Court cases between the acupuncture boards and the physical therapy boards. So if there's a way forward and there's a way to reach across the aisle, Ray and I are all for that to really help better the professions as a whole. And really help individuals as much as we possibly can.
100%. Yeah, I mean, the way forward for rehab is, I say this every class, we have to learn from each other. And we all bring something to the table, and, we're all amazing at different things. But I think until we get to the point where we're able to provide treatment which is multimodal and really something that honors all the different rehab professions in a way which is interdisciplinary, we're going to continue to miss the mark. So,
yep. Perfect. Well, Grant, Ray, thank you guys so much for joining me on another webinar and joining the Torrentia Webinar Wednesday series. Grant, I know it's crazy for you guys. Janae, I see you in here as well. Ray, I know life's a little hectic and crazy right now, so I'm glad that everybody's able to get on these and get more information out there surrounding this. So if you're just now, if you maybe missed part of this or you had to step out early, just always remember you can go back and watch that in this episode in the webinar archive under the functional medicine and rehabilitation content.
As long as we can talk about PAMPs and DAMPs, I'm a happy guy, you know what I'm saying?
All right. Well, thanks so much, guys.
Yep. Thank you, guys. It's fun as always.